Hi everyone, I'm Sandeep. I'm one of the cardiology fellows here at the University of Arizona, Tucson. As a part of my away elective, I had a chance to work with Dr. Bruce Gray at Prisma Health Greenville, and this is one of the cases I wanted to share with you all. It's a 42-year-old lady who was referred with 2 months of right lower extremity swelling and no clear diagnosis. She was noted to be hemodynamically stable with dilation of multiple small superficial veins and pitting edema. There was no inguinal lymphadenopathy or masses that we could palpate. She already had 2 venous duplexes, as I mentioned, which were negative for DVTs. A CT of her pelvis was done, and that showed an ovarian cyst. However, when we looked at the scan, we saw some abnormality in the right inguinal area, although we were not sure what it was. A workup so far, she had mild anemia, but nothing really important that stood out. A thrombophilia workup was done, and that was negative. So we repeated a venous duplex to further evaluate this abnormality we saw on the CT, and this time we saw some abnormal flow in the right external iliac vein. We really couldn't look anything beyond that. So we started treatment with rivaroxaban as a treatment dose for DVT and decided to proceed with the Venogram just because things were not adding up in the right way. In the Venogram, as you can see, there is complete occlusion of the right external iliac vein and collateral flow taking blood back to the IVC. Aspiration thrombectomy was done and we were able to recanalize into the IVC. But as you can see closely, there is this dilation of the right external iliac vein and filling defects that's extending all the way from the external iliac vein to the common iliac vein with this aneurysmal component that was noted here. But long story, we were able to recanalize, we were able to get flow back into the IVC. So we knew there is a component of thrombus here. So we decided to proceed with catheter-directed thrombolytic therapy for at least 12 to 14 hours and see what happens. After about 14 hours of catheter-directed thrombolytic therapy, we bring her down, and what were we expecting to see? What we saw was essentially the same thing as how we ended the day one. There was better recanalization, but you still have this huge filling defect in the right external iliac vein and the common iliac vein. At this point, we were sure that we are dealing with something beyond a simple thrombus. So we went ahead with a bioptome and proceeded with a biopsy of this lesion through the sheath. And what it turned out to be was a leiomyosarcoma. At the time of the diagnosis, she had no other mets on any of the cross-sectional images that we did of the head, chest, abdomen, and pelvis. So she went ahead with a complete right lower extremity amputation with disarticulation of her right hip with debridement. But sadly, 6 months later, we see this. She has mets in her liver and mets in her left thigh. And as you can see, this right hip has been disarticulated. A quick discussion on leiomyosarcomas. It's rare. It's less than 1% of all cancers. And up to 0.5% of leiomyosarcomas can involve the IVC and its branches. Because of this rareness, there's no real definitive treatment or management strategies laid out for this particular type of malignancy. The diagnosis is often delayed because they have very non-specific symptoms and often get misdiagnosed as a venous thromboembolism, like in this case. They metastasize early and the prognosis is usually poor. A few quick take-home points with this case. The first thing being that don't hesitate to go with a multimodality approach in diagnosis of venous cases, especially when things don't add up the right way. Depend on your venous duplex, a CT venogram, and sometimes even going with a conventional venogram to arrive at the diagnosis. Malignancies are rare, but keep that in your differentials, especially when things are not adding up exactly like how we mentioned in this particular case. And thirdly, the most important point, be very careful about a shotgun approach in thrombophilia testing. For example, factor V Leiden mutation is pretty ubiquitous in up to 5 to 7% of the population. God forbid if this lady was positive for heterozygous factor V Leiden mutation, this would have been resigned as a DVT and the entire workup towards a malignancy would have been ignored. So this was a quick short summary of the case that we saw with Dr. Gray, and a special thanks to him for helping me work on this particular one.